Good evening, everyone, and welcome to this long marathon of 200 hours to do a revision of 10,000 clinical vignettes. That is all that you need to practice to crack 99 percentile in USMLE Step 1. So every day in 1 hour, we will try to do the revision of around 60 clinical vignettes, clinical case vignettes, relevant image, and the clinical case. That is the format in which the questions are asked in the USMLE Step 1. Once you solve these 10,000 clinical case vignettes, I'm sure no one is going to stop you from cracking your dream residency in America. So let's make the great beginning, doctor. 45-year-old female with progressive dyspnea for the past 6 months. How is the FEV1 by FVC ratio? It is 90%. How is the lung volume? Lung volume is reduced. So what type of pattern it is? All of you know, there are two patterns that you need to remember when it comes to the lung disease. One is obstructive lung disease, other is called restrictive lung disease. In restrictive lung disease, you have a shrinkage of the lung volume, whereas in obstructive lung disease, you have hyperinflated lungs. That is what you need to remember. So there's a reason, there's a reduced lung volume, FEV1 by FVC ratio is 90%, and this pattern is consistent of what? It is typically consistent of restrictive lung disease, where both the FEV1 is reduced and also FVC reduced. Both of them are reduced, but overall FEV1 by FVC is normal or only slightly increased. So that is the reason FEV1 by FVC ratio, if it is not significantly decreased but almost normal, that is very classical of restrictive lung disease, because in restrictive lung disease, both the FEV1 and FVC are equally decreased. That's the reason as a ratio, it is almost normal, is what you have to remember. Now, if you look at the pattern, you have a normal curve, you have a restrictive curve, you have a obstructive curve. So normal is peak expiratory flow rate is normal. And the pattern is initially it is a rapid decline, then decreasing steadily. And the volume of the lung is normal. Whereas in restrictive pattern, what do you typically see? You have to recognize in the tomorrow's exam based upon the image of restrictive and obstructive, whether this is this or that. So in restrictive pattern, the peak expiratory flow rate is slightly reduced or only normal, almost normal, right? But the lung volume as such is reduced compared to normal. That's very important. And the pattern is almost normal. And the volume, if you take the volume is reduced compared to normal, the lung volume in restrictive. How about obstructive? In obstructive, the peak expiratory flow rate is significantly reduced. And the pattern is a concave pattern. And the volume is very much normal or reduced. So that is what you need to remember. And a good number of times, there is also hyperinflated lung also, because of an increase in residual volume in case of the obstructive pattern. So what is most important, doctor? FEV1 by FVC, whenever it is normal, think of restrictive lung disease. FEV1 by FVC significantly decreased, then consider the possibility of obstructive. So this is very important point that you need to remember. Now, let's go to the next clinical case vignette. A 30-year-old male diagnosed with HIV is being started on abacavir. He develops fever, rash, malaise within a week. So what is the most likely possibility? So you should know those who are put on abacavir typically have a abacavir sensitivity, hypersensitivity. And it is often associated with HLA B5701, HLA B5701, with which abacavir hypersensitivity is related. So that is the reason you need to do the genetic testing for HLA B5701 whenever you are starting abacavir as a part of the highly active antiretroviral therapy is what you should understand. Now, the next clinical vignette. A 70-year-old man with a history of smoking has hypertension, presents with abdominal pain, which is radiating to the back, interscapular area. And the imaging shows calcification of the abdominal aorta. So what is the most common predisposing factor for abdominal aortic aneurysm? Typically in elderly people, when there is an atherosclerosis, that is a predisposing factor for the abdominal aortic aneurysm. So if you look at the image, you can see there is a calcification, there is calcification so clearly. And there is an aneurysmal dilatation of the abdominal aorta. So that is the reason the MRI, the CT, ultrasound, any of them can actually reveal the presence of the abdominal aortic aneurysm, where smoking, atherosclerosis, hypertension, they're all the predisposing risk factors is what you should remember. Now, the next clinical case vignette. A 65-year-old male with known history of abdominal aortic aneurysm presents with a sudden onset of the abdominal and back pain. He develops hypotension, pulsatile abdominal mass. There is an abdominal mass which is pulsatile. So this is the classical clinical presentation of a ruptured abdominal aortic aneurysm, and it's a surgical emergency is what you need to remember. So this is how intraoperatively, if you look at the abdominal aortic aneurysm which has undergone rupture. So remember, hypertension predisposes to abdominal aortic aneurysm. The moment abdominal aortic aneurysm ruptures, that lead to significant hypotension is what you need to remember. Now, doctor, a 60-year-old female with atrial fibrillation, the atria are shivering. Sudden onset of severe diffuse abdominal pain. And this abdominal pain is out of proportion to what you are seeing on physical examination. You thought maybe there is a perforation with this much a significant abdominal pain, but there is no rigidity, abdominal rigidity. So physical clinical signs are very minimal, but clinical symptoms, abdominal pain is very severe and disproportionate to the physical signs. This is the classical presentation of acute mesenteric ischemia. Whenever the mesenteric vascular thrombus goes and lodges in the mesenteric vessels, that lead to mesenteric ischemia, which lead to abdominal pain severely disproportionate to the signs. Symptoms are disproportionately severe compared to very mild clinical signs is typical of acute mesenteric ischemia is what you need to basically remember. Yeah. So Sparkle is asking, I want to give my first attempt in 2025. Could you give some tips at the end of the session? So every day I conduct 1 hour of session, around 60 clinical case vignettes, right? We'll have a discussion. Totally 10,000 clinical case vignettes for USMLE step 1 and 10,000 clinical case vignettes for step 2. That is all the gyan that you need to have. So that is the reason, follow me every day on the YouTube. But after the session is over, we will remove this video and archive it into our video library. So take a subscription of our video library. Okay. So this is how you see, doctor. When you do the imaging, you can see there is a thrombus which lodged in the mesenteric vessel, which is leading to mesenteric ischemia, because of which the abdominal pain is what you see, especially after taking the food. When there is an expectation of a 1 minute, doctor. Can you please punch? Is my voice loud and clear for all of you? I hope so. So, whenever you take food, then you expect increased blood flow to the mesenteric vessels. But the moment there is any thrombus in the mesenteric vessel, then that increase in blood flow doesn't occur and abdominal pain will be more severe after taking the food. That's called as postprandial abdominal angina. After taking food, there's a development of severe abdominal pain, which is a very classical history to confirm that it is acute mesenteric ischemia because of a embolic occlusion of the mesenteric vessel is what you have to remember. Now, doctor, 55-year-old male with a history of cirrhosis, presents with fever, abdominal pain, cloudy ascitic fluid. So what is your diagnosis? It is spontaneous bacterial peritonitis is the one which you need to suspect. If you do ascitic fluid analysis, then it will show an elevated neutrophil count. When do you call elevated neutrophil count in abdominal ascitic fluid, doctor? Whenever the neutrophil count is more than 250 cells per millimeter cube, you call it as the elevated neutrophil count, which is classical of spontaneous bacterial peritonitis. So this is how you can see a patient with cirrhosis who is having ascites. So you can also appreciate the ascitic fluid when you have done the ultrasound, right? You can also appreciate the presence of the ascitic fluid when you have done the CT imaging. So this patient, whenever he develops fever and you have taken out the ascitic fluid, you found neutrophil count more than 250, then that is a very important indicator of spontaneous bacterial peritonitis, which is very common in the patients who are having liver dysfunction, cirrhosis of the liver with ascites is what you have to remember. So now, doctor, 50-year-old female with a history of chronic kidney disease. There's a diffuse abdominal pain presenting to you. Always imagine the clinical cases that you are in the middle of the emergency ward, or you are in the middle of an intensive care unit and you are managing the case. That is how you need to imagine, right? Now, there is a hyperkalemia, hypermagnesemia. So what could be the cause for the abdominal pain? So always remember, hyperkalemia can present in the form of abdominal pain. Another favorite question of the examiner: what is the relation between the changes on the ECG and the potassium levels? So whenever the potassium level is 5.5 to 6.5, almost normal, but 6.5, very early, you get peaked T waves. 6.5 to 7, there's a progressive paralysis of the atrium. That's the reason the P waves will undergo widening and flattening. There is a PR prolongation. The P waves eventually disappear. Then 7 to 9, when the potassium levels are between 7 to 9, there will be conduction abnormalities, especially bradyarrhythmia, sinus bradycardia, high-grade AV block with a slow junction and ventricular escape rhythm, and prolonged QRS interval. They're all the features whenever the potassium levels hit 7 to 9. Then when the potassium levels are more than 9, all this will be there, and ultimately there is an appearance of sine wave pattern. Following that, there will be an asystole, ventricular fibrillation, etc., etc. So you should know, based upon the level of the potassium, what is the sequence of the appearance of the ECG changes is the favorite question of the examiner. Now, abdominal pain can be the presenting feature of hyperkalemia. That is the take home from this clinical case vignette. Now, 60-year-old male with a history of weight loss, early satiety, presents with epigastric pain. There is also a palpable mass. So based on this, what is the most likely possibility in a 60-year-old man with a history of weight loss, early satiety, epigastric pain, palpable mass? So it is typically suggestive of advanced gastric cancer, and you need to do endoscopy to prove the diagnosis. So tomorrow's USMLE step 1, you need to be sure to identify a gastric carcinoma. When you do ultrasound, how it looks like. So this is the typical appearance in a given patient in 1999 to 2002, where it is not very prominent. In 2003, it has grown, and by 2004, it has grown more, and by the 2007, it has grown into a proper mass. This is how the gastric carcinoma typically grows and presents with weight loss, epigastric pain, and early satiety is what you have to basically remember. So now, doctor, a 55-year-old female has recurrent episodes of abdominal pain. There is also fatigue, there is bone pain, there is hypercalcemia, elevated parathormone level. Always remember, hyperparathyroidism is equal to hypercalcemia. Hypoparathyroidism is equal to hypocalcemia is what you have to basically remember. So the patient most likely who has a fatigue, who has a bone pain, hypercalcemia, elevated PDH is equal to primary hyperparathyroidism, which can lead to abdominal pain because of the presence of hypercalcemia is what you need to remember. So what is the most common cause of the primary hyperparathyroidism, doctor? So you should remember, it is the parathyroid adenoma. Parathyroid adenoma, which is responsible for the primary hyperparathyroidism is what you should remember. Now, a 10-year-old boy has a rash on the extremities. There is an abdominal pain, there is arthralgia, rash, abdominal pain, arthralgia. These all are the features of the vasculitis. Why abdominal pain? Because there is a mesenteric vasculitis, abdominal pain. Similarly, why there is rash? Whenever vasculitis is there, vasculitis can lead to vasculitic purpurae, which are palpable purpurae, which present like a rash on the lower extremity. So these are all the features typical of IgA nephropathy, otherwise called Henon-Conlin's purpura. Henon-Conlin's purpura, where the abdominal pain is because of the vasculitis of the mesenteric vessels is what you need to remember. Now, in this individual, you can be able to do the histopathology, which will show the presence of vasculitis. And you can also see the presence of mesenteric ischemia because of the vasculitis. And because of that mesenteric ischemia, there are hemorrhagic lesions in the bowel in case of Henon-Conlin's purpura, which is the other end of the spectrum of IgA nephropathy is what you need to remember. So vasculitis is one of the most high-yield topics in USMLE step 1. 25-year-old female presents with recurrent lower abdominal pain. Recurrent lower abdominal pain. But if she goes to washroom, have defecation, even if a little stool comes also, the pain is getting relieved. Because of that, there is a change in stool frequency and consistency. So this is classical of irritable bowel syndrome, and you need to do the symptomatic management. So Irritable bowel syndrome is a sort of a psychosomatic disorder where the patient will have abnormal contractions of the bowel, which lead to a painful situation where unless he goes and passes a little stool, then he will get a relief of the abdominal pain, and that increases the frequency of passing the stool is what you need to remember. Now, doctor, if you look at the way we approach the clinical problem of irritable bowel syndrome, you should know the algorithm, right? Whenever symptoms which are compatible with irritable bowel syndrome are there. So what are the symptoms? Abdominal pain, which is related to defecation, associated with a change in stool consistency and stool frequency. Then you need to send routine blood workup and also celiac sprue serology, right? Then if it is normal, you need to look for any alarm symptoms that it is not simple psychosomatic irritable bowel syndrome, but there is any alarming symptoms for organic lower GIT disease. So what are the alarming symptoms of organic lower GIT? Family history of IBD, celiac disease, nocturnal diarrhea, age more than 50, female gender, or proton pump inhibitor or NSAID use, and the duration of the symptoms is less than 12 months. They're all considered to be alarming symptoms which are suggestive of the more severe organic pathology. So once they are not there, look whether there is any diarrhea. So if there is diarrhea, consider the SHACAT test, SHACAT scan. Yeah. Then check fecal calprotectin. Suppose if it is abnormal, then do colonoscopy. Right? And if the colonoscopy is abnormal, then you need to manage the organic pathology. So this is how you approach algorithm for approaching a patient presenting with altered stools, altered consistency of stools, altered frequency of stools, where you are suspecting irritable bowel syndrome is what you need to remember. Now, a 40-year-old male with a history of alcohol use presents with hematemesis after repeated vomiting. So what is the most likely diagnosis? It is a Mallory-Weiss syndrome, where there is a mucosal tear at the level of the gastroesophageal junction because of forceful vomiting is what you need to remember. So this is how, if you do endoscopy, you can see the mucosal tear at the lower gastroesophageal junction, right? Lower esophagogastric junction. That is a point where you can see the presence of the mucosal tears in Mallory-Weiss endoscopy. You should know how to identify. Now, 35-year-old female, recurrent episodes of pancreatitis, is having pancreatic division. When you have done the MRCP, magnetic resonance cholangiopancreaticography. So what is pancreatic division? It is a congenital anomaly that can lead to recurrent pancreatitis associated with abdominal pain. So what are the various structures you will recognize here, doctor? So this curved arrow which you are able to see is the main pancreatic duct. So you should know how to identify the structures on MRCP. Then you can see the ventral duct and common bile duct. Ventral duct is the open arrowhead, right? Ventral duct is the open arrowhead. And the common bile duct is the arrowhead. You can see here, right? Arrowhead. They drain through the major papillae, which is the long arrow. So this is the pancreatic division, which presents with recurrent pancreatic episodes with abdominal pain, is what you need to basically identify. Now, a 65-year-old male with a weight loss, jaundice, vague abdominal pain, CT scan is showing a mass in the head of the pancreas. So whenever significant weight loss is there, jaundice is there with vague abdominal pain in an elderly person, then you should suspect pancreatic cancer, which is causing the biliary obstruction, because the head of the pancreas, if you look at the tumor, which is an ampullary area, you can see the head of the pancreas mass is causing a compression of the pancreatic duct and also the bile duct. So you get a double ductal dilatation whenever the pancreatic head tumor is there, is what you need to remember. Very nice to see Madhu and many more who are all online. Thanks for joining. So every day we have, preferably in the morning, 1 hour, 60 clinical case vignettes for USMLE step 1, and in totally 200 days we finish totally 10,000 clinical case vignettes for USMLE step 1. And of course, in the evening we have our regular class, right? So we'll try to take care of both USMLE students and other medical licensing exam students in 2 different sessions, right? So please do subscribe, like the video, share the video with all your friends. A 45-year-old male with a weight loss, fever, abdominal pain, libido reticularis, all this is typically suggestive of polyarthritis nodosa. Polyarthritis nodosa is a vasculitis which affects medium-sized arteries. So that is the reason in polyarthritis nodosa there is also mesenteric vasculitis, which lead to abdominal pain. And how do you identify polyarthritis nodosa, doctor? If you happen to see there are dilated nodosal blood vessels, right? Aneurysms in the renal vessels, which is very classical of polyarthritis nodosa, is what you need to remember. Many times an image-based question is being asked in this context. Now, a 60-year-old female with a history of smoking presents with a postprandial abdominal pain with a significant weight loss. So whenever there's a weight loss, postprandial abdominal pain, you should always think about mesenteric vasculitis. So this is how, if you do the angiography, you can see the presence of mesenteric vasculitis is what I want to underscore. Now, a 30-year-old female presents with left flank pain. There is hematuria, abdominal pain, hematuria, abdominal pain. There is a compression of the left renal vein between aorta and the superior mesenteric artery. And what is your diagnosis? This is called nutcracker syndrome, where the left renal vein is compressed between aorta and the superior mesenteric artery. Between the two, the left renal vein gets compressed, just like you put something into your axilla and press it, right? So one is superior mesenteric artery, other is aorta. Between the two, the compression of the left renal vein, which is called nutcracker syndrome, is what you should remember. So this is how a nutcracker, I think you understood, you can align what is a nutcracker. So if you look at the imaging, you can see between the aorta and the superior mesenteric artery, the renal vein, left renal vein, this is left. So left renal vein is the one which is basically pressed. So this is how you can see. Another way of looking at it is, this is the superior mesenteric artery, this is the superior mesenteric artery, right? And this is the aorta. Between the two, the left renal vein, which is trying to reach out to the kidney, is the one which is being compressed in nutcracker syndrome, is what you have to understand. Now, a 45-year-old female, can online students can punch? Is the voice loud and clear? Are you able to appreciate the size of the letters and also the image? Right? This is a better format. Instead of sitting before the laptop and then moving the mouse and trying to deliver a class, this is much better way, like a real class, right? Now, a 45-year-old female with obesity presents with the right upper quadrant abdominal pain, fever, positive Murphy's sign. So what is it? Positive Murphy's sign. What is Murphy's sign? Whenever you apply the pressure under the right lower rib cage, then the patient will hold the breath at the time of inspiration, right? Due to the tenderness and pain. That is because of a inflamed gallbladder will come and touch your examining hand whenever you are taking deep inspiration. That's the reason whenever cholecystitis is there, if you put your examining palm under the right lower rib, then the inflamed gallbladder touches it and the patient will hold the breath. That's called Murphy. So Murphy's sign is a feature of acute cholecystitis where the gallbladder get inflamed. Commonly, it is the gallstone which is obturating, leads to the wall of the gallbladder to get inflamed. In the case of the acute cholecystitis, is what you need to basically remember. Now, doctor, is this font okay? Or you want me to increase the font? This is another option. This is another option. You want this better or this better? Please let me know. You want a zoom? Yeah. So today, technology is very interesting. Earlier days, we used to write on the boards, then sit on the laptop and then project the screen and then look into the slides and teach. No, that's all not interesting. A digital board is a revolution, right? So thanks for attending the session. I'm so happy to see 15 online classmates. Please tell your friends, Dr. Murali Bharadwaj comes every day online. 200 hours, 10,000 clinical case vignettes for the USMLE step 1. Another 200 hours, 10,000 clinical case vignettes for USMLE step 2. That's all that you need to get 99 percentile score, doctor. Good view. Very good. Thank you. Now, a 50-year-old presents with localized abdominal pain. There's a bulge along the lateral edge of the rectus abdominis. So what is this? This is classically Spigelian hernia, which requires surgical repair. If you do imaging, doctor, you can see along the Spigelian hernia, which is trying to project along the lateral part of the rectus abdominis. This is how you identify when you do the CT scan. Now, the next clinical case vignette, a 55-year-old male with a history of alcohol use, with abdominal distension, prominent veins radiating from the umbilicus, classical description of the caput medusae. You can see how prominent can the caput medusae can become. You need to identify that as one of the features of the cirrhosis of the liver with portal hypertension is what you need to understand. Now, a 60-year-old male with a history of previous abdominal surgery. Previously, there was an abdominal surgery. Now presents with a bulge at the site of the surgical incision. So, which is a very classical of an incisional hernia, which is a ventral hernia, which in turn requires a surgical repair by placing a mesh. So this is how you can see the previous surgery with a divarication of the recti will predispose to the development of the incisional hernia, which is treated by placing a mesh and preventing the recurrence of herniation. Now, a 35-year-old male presents with horizontal diplopia. Horizontal diplopia. There's an inability to abduct the right eye, so which is very classical of the abducens palsy. this eye is unable to abduct. That's the reason the primary position has become medial deviation. In the case of the oculomotor palsy, in the case of the abscess palsy, is what you need to understand. So what is the cause of the abscess palsy? Any raised intracranial pressure or any trauma or ischemia can lead to the development of abscess palsy. Now, a 40-year-old female presents with shoulder pain with weakness, particularly while initiating abduction of the arm. So this is a classical presentation of rotator cuff tear. So there are so many rotator cuff muscles. What are the four muscles? Supraspinatus, infraspinatus, teres, right? And SITS. So sits. So four muscles. Out of that, it is a supraspinatus muscle which is most commonly injured in rotator cuff tear, which makes an inability to raise abduct the hand is what you need to remember. Now, a 30-year-old female presents with a waddling gait, like a duck is walking, a waddling gait. So there is a hip pain, there is a Trendelenburg positive, typically it occurs whenever the gluteus medius or minimus is weak. As you know very well, for example, if you have this gluteus medius and minimus on this side, so it will pull down so that side pelvis doesn't sink when the leg is unsupported. But if this is weak, it cannot be able to pull it up when the leg is unsupported. That's the reason it will sink, which is called Trendelenburg positive. If bilateral gluteus medius and minimus are affected, when you are walking, every time the leg is, while walking, definitely you need to lift one leg. Every time you are lifting leg, that side will be sinking down and it looks like a waddling duck is what you need to remember. So now, doctor, a 45-year-old male presents with a weakness in abduction of the little finger following the wrist injury. So what does it suggest? Little finger innervation abductor digiti minimi is innervated by the ulnar nerve. Ulnar nerve, you can see this is the abductor digiti minimi. This is the flexor digiti minimi brevis. This is the flexor pollicis brevis. This is the abductor pollicis brevis. So you should know all the small muscles, how to identify them anatomically for the tomorrow's USMLE step 1 exam. Now, a 50-year-old female presents with numbness and weakness in the thumb, particularly when the thumb is abducted. It is consistent with median nerve injury. Thumb abduction is associated with median nerve. So, carpal tunnel syndrome, which affects the median intern innervates the abductor pollicis brevis muscle, is what you need to remember. So, the various tests, this is called you are tapping and there is a pain reproduced, that's called Tinel's sign. Then whenever you are trying to flex, then there is a pain which is called Phelan's sign. And this is how you test the abductor pollicis brevis. And once there is the involvement of the median nerve, there is a sensory loss on the index finger, right? So that's the reason you will elicit it by doing 2-point discrimination test is what you need to understand. So now, doctor, a 10-year-old child presents with failure to thrive. Very important. Failure to thrive. There is an ataxia, fat malabsorption, and blood is showing acanthocytes. All these are suggestive of a beta lipoproteinemia, where the apolipoprotein B is completely absent, that lead to fat malabsorption and neurological symptoms is what you need to remember. So if you look in peripheral smear, what do you see, doctor? Acanthocytes, which are seen in the case of the beta lipoproteinemia, is what you need to remember. A 70-year-old male with metastatic castration. Castration-resistant prostate cancer. So why do you do castration in case of prostate cancer? Because prostate depends on testosterone, just like the terrorists depend on black money, right? That's the reason cash is being banned, only card is permitted. Or bank transactions, UPI, they are only permitted. Cash is banned because cash is the petrol ignition for the terroristic activity. Similarly, in the prostatic cancer also, testosterone promotes the prostate cancer growth. That's the reason the source of testosterone comes from testis. That's the reason we do castration. But sometimes even castration-resistant metastatic prostate cancer is being started on abiraterone. He is being started on abiraterone. 1 minute. Abiraterone. So whenever the abiraterone, what exactly abiraterone will be doing? Abiraterone inhibits the CYP17, an enzyme which is involved in androgen biosynthesis. And it reduces the androgen production, tumor progression. So that is the mechanism of action of abiraterone is the drug that you need to remember. So this is the testosterone synthesis reduced by CYP17 inhibition. CYP17 inhibition by abiraterone. Then even if testosterone is produced, that can be prevented to bind with the androgen receptor. And what is that drug called as? It is enzalutamide. Enzalutamide. Then there is a radiation, alpha radiation of the cancer cells, which is done with radium-223. We are talking about the metastatic prostatic cancer treatment options. And suppose the metastatic prostatic cancer will lead to osteoblastic metastasis. Then we use what is called as zoledronic acid, and we also use denosumab, which will inhibit the osteoclast. So these are the various options, treatment options to treat the metastatic prostate cancer is what you have to remember. Now, a 25-year-old male with a severe head injury presents with abnormal posturing. Arms are extended, internally rotated. Arms are extended, internally rotated, while the legs are extended. So it is an example of decerebrate rigidity, indicating that the brainstem is the one which is damaged. Okay? So you should know decerebrate and decorticate posturing. Decorticate posturing, you have rigid extended legs, pointed and turned in toes, arms bent towards the body, and curled wrists and hands, balled hands against the chest. So this is decorticate. Whereas you can see decerebrate. In this, both the elbow and also the legs, both of them are in extended posture. If both of them are extended, you call decerebrate. If the hands are flexed, you call it as the decorticate, which you need to basically remember. So decerebrate rigidity indicates, the decerebrate rigidity typically indicates the brainstem is damaged. Whereas decorticate posturing is above the level of the red nucleus, and typically you find the wrist in a flexed posture is what you have to remember. Now, a 30-year-old female with irregular heavy menstrual bleeding for the past 6 months. So what is the differential diagnosis for the 30-year-old female with dysfunctional uterine bleeding? Polycystic ovarian syndrome, endometrial hyperplasia, similarly uterine fibroids. That's the reason what do you need to do? You need to do the endometrial biopsy. Endometrial biopsy can turn out to be typical hyperplasia or atypical hyperplasia or frank adenomatous change, which is endometrial carcinoma, is what you need to basically remember. Now, doctor, a newborn presents with jaundice, with anemia, hepatosplenomegaly shortly after the birth. The mother's blood group is type O and the baby's blood group is type A. So whenever such a dissociation is there, then that lead to ABO, hemolytic disease in the newborn, which is less severe compared to that of the RH incompatibility. So what are all the differences between ABO incompatibility and RH incompatibility? One of the favorite questions of the examiner. So typically the frequency, if you look, ABO incompatibility is more common. In ABO incompatibility, mother is O, right? Typically mother is O, fetus is A or B. And usually the first pregnancy get affected. And severity is mild in case of ABO. And there is a spherocytosis in the peripheral smear. And it is weakly positive or negative on direct Coombs test. And it is prevention, you have no way to prevent. Whereas in the case of RH, hemolytic disease of the newborn, due to the RH incompatibility, it is less common. Mother is RH negative, fetus is RH positive. Usually it is the second pregnancy which is affected, unlike the first pregnancy affected in ABO. And it is generally severe, it leads to erythroblastosis, and direct Coombs test is strongly positive, and you can avoid it by giving Rogam. RH immunoglobulin is what you have to remember. So that is the story of ABO incompatibility. The next favorite clinical case vignette based question. A 24-year-old female, unplanned pregnancy, opts for medical abortion and given mifepristone and misoprostol. How do they act? Mifepristone is anti-progesterone, and misoprostol is an anti-metabolite which induces the abortion by causing uterine contractions. So you can see mifepristone acts on the progesterone receptor. It is the first pill that we give to induce abortion. The first pill blocks the progesterone receptor. Then typically what you can see, 12 hours later, you will be giving the second pill, which is the misoprostol. And it causes the uterine contraction and cervical dilatation and induces the abortion. So mifepristone and misoprostol combination is the one which you will be using. So doctor, a 45-year-old male presents with fever, headache, neurological deficit. MRI shows a ring-enhancing lesion in the brain. So what does it suggest? It suggests a brain abscess. So remember, a ring-enhancing lesion in the brain is a typical finding on MRI in case of the brain abscess in a patient who is having fever, and it requires the surgical drainage. A 30-year-old male presents with painless fluctuant swelling on his back. He has recurrent skin infections. So what does it suggest? Cold abscess. Cold abscess is caused by Staphylococcus aureus, especially in an immunocompromised individual where it presents without the classical signs of inflammation like pain, is what you need to basically remember. Very good. Dr. Goyal says brain abscess versus tuberculoma. So how do you differentiate? Yes. In our radiology section, we will take in a more detail. How do you differentiate tuberculoma from a cavitating metastatic lesion to the brain versus neurocysticercosis, cerebral lymphoma, and the brain abscess? What are the differentiating features of all this? Is one of the favorite radiology question, right? Now, so cold abscess typically presents without the signs of rubor, calor, and dolor, which are classical of the inflammation, is what you need to remember. Now, a 55-year-old male with a history of alcohol disorder typically presents with cough, fever, foul-smelling sputum, chest X-ray showing cavity lesion, typically in the right lungs, upper lobe. So what does it suggest? Typically, an alcoholic is predisposed to Klebsiella pneumoniae. And whenever there is an aspiration, the aspirated pneumonia can turn into a cavitating abscess. So this is how you can find the presence of a cavitating right lobe, right upper lobe abscess in the case of a alcoholic individual, which is typically caused by the Klebsiella, is what you need to remember in the tomorrow's USMLE. Now, 40-year-old male with a fever, right upper quadrant pain and jaundice. Ultrasound is showing hypoechoic lesion. So what is it consistent? It is consistent with liver abscess, which can be caused by bacteria, parasites, fungi, and you need to do the drainage, and antibiotic therapy is all that you need to give. So this is how typically a pyogenic liver abscess is typically identified when you do the ultrasound exam, is what you need to remember. Now, a 60-year-old male with a history of alcohol abuse, with a productive cough, fever, foul-smelling sputum, there is a cavity with a air fluid level in the lung. So this is a typical lung abscess which can occur secondary to aspiration. So what you can see here, doctor, you can see in the right lobe, lung abscess secondary to aspiration is what you need to remember in a alcoholic individual, and it need to be treated with antibiotics and drainage is what you need to remember. A 25-year-old male with the irregular menstrual cycles, hirsutism, obesity, ultrasound is showing multiple ovarian cysts which are present like a chain of lakes. So what is that, doctor? Like a pearl necklace appearance, which is typical of polycystic ovarian syndrome. So you should know how to identify multiple polycystic kidney disease and what are the criteria. How is the LH? How is the FSH? How is the androgen levels in case of the PCOD? Everything you should know for the tomorrow's USMLE step 1. Now, doctor, a 10-year-old boy presents with progressive motor and cognitive decline. MRI show white matter changes. Genetic testing show ABCD1 gene mutation, which is all classical of X-linked adrenoleukodystrophy, which is a paroxysmal disorder. Which typically affects both the CNS and also adrenal glands. So you should know typically so in the nucleus, ABCD1 mutation is there. So that will typically affect the beta oxidation in peroxisome. That lead to free radical injury leading to mitochondrial dysfunction. That in turn will lead to the neurodegeneration and also adrenal insufficiency. Adrenoleukodystrophy is the name of the disorder, which is a peroxisomal disorder, which is because of the ABCD1 mutation is what you have to ultimately remember. Right, doc? So, are you all liking the digital board? Digital board, which is a better way and looks more like a live face-to-face class, right? Instead of sitting, teacher sitting before a boring computer and you also sitting before a computer, right? Now, doctor, comes our number 42 clinical case vignette. Like this, we are going to discuss 10,000 clinical case vignettes over a period of 200 hours in 200 days for our preparation to USMLE step 1. All that you need is the funda of these 10,000 clinical case vignettes, which will make you ready to score 99 percentile in USMLE step 1. Right, doctor? Now, a 30-year-old male on HIV therapy with abacavir develops fever, rash, GIT symptoms. Just before we discuss, HLA-B 5701 is the one which is strongly associated with abacavir hypersensitivity in the retroviral patients is what you need to remember. So now, A 4-year-old child has spasticity, hyperreflexia, abnormal gait, scissoring gait. Gait is as such a scissor, like a scissor is walking, right? And there is a spastic cerebral palsy, typically because of the perinatal brain injury. But remember, cerebral palsy is a static neurological disorder. It is not a progressive neurological disorder. So this is how typically the guide will be scissoring guide because of the spasm of the adductor muscles or the thighs is what you have to remember. Now, a 45-year-old female presents with heavy menstrual bleeding and anemia. Ultrasound shows thickened endometrium. So endometrial biopsy was done and typically there is hyperplasia. So endometrial biopsy is mandatory and you should know what are the indications of endometrial biopsy. Now let us look at the indications of endometrial biopsy, right? Now, abnormal uterine bleeding, number one indication. Postmenopausal bleeding. And suppose if there is any history of hereditary non-polyposis colon cancer, they are also at risk of developing endometrial cancer. That's the reason you need to remember. Hereditary non-polyposis colorectal cancer. Detection of precancerous hyperplasia. Any endometrial dating. You want to know whether endometrium is rich enough, mature enough to receive implant in IVF. There also we do endometrial biopsy. And any previously diagnosed endometrial hyperplasia, you need to seriously do the endometrial biopsy. You want to know whenever you are giving hormone therapy in dysfunctional uterine bleeding, whether endometrium responding or not, you need to do endometrial biopsy. Similarly, 1 year of amenorrhea, you want to evaluate, then endometrial biopsy. Infertility evaluation, we do the endometrial biopsy. Abnormal pepinoculum stain, right? Smear with atypical cells which are favoring the endometrial origin. They are called as atypical glandular cells of unknown significance. It's called AGUS. AGUS. You need to remember is an indication for endometrial biopsy is what you need to ultimately remember. So, doctor, good. 25-year-old male who has undergone blood transfusion develops fever, chills, back pain within minutes. So what is this? It is acute hemolytic transfusion reaction because of the ABO incompatibility. And how do you treat? Immediately stop the transfusion and give the supportive care is what you need to remember. So group A guys have antibodies of anti-B and antigens of A antigen. Group B guys have anti-A antibodies in plasma and B antigen. Group AB guys don't have antibodies in plasma, they are universal recipients and they have both A and B antigens. Whereas group O have antibodies against both anti-A and anti-B and they have no antigens, neither A antigen nor B antigen. Hence, they are universal donors is what you have to ultimately remember. Now, a 22-year-old presents with acute onset of the right quadrant abdominal pain, fever, anorexia. So, it is consistent with acute appendicitis. Always remember, anorexia is the rule in appendicitis. If the patient says, no, I'm feeling hungry, means it is never appendicitis. Anorexia is the rule in case of the appendicitis is what you have to remember. So there are two signs. One is called Murphy's sign, where there is typically palpating in this area at the McBurney's point, right? Then there is a tenderness, McBurney's sign. The other is in the opposite quadrant. If you happen to left lower quadrant when you palpate, then there is a tenderness in the right lower quadrant, because in the right lower quadrant you are having the appendix inflamed. So when you apply pressure in the left lower quadrant, then there is a distension of this inflamed segment because the gas is being displaced back and there's a distension of the appendix which is inflamed. That leads to the development of the pain is what you have to basically remember. So now, doctor, 55-year-old male with a history of the alcohol, severe epigastric pain radiating to the back. Oh, doctor, I cannot lie down on my back. Oh man, it's paining more when I lie down on my back. History of alcohol. So then you need to suspect possibility of pancreatitis because pancreas is a retroperitoneal organ. That's the reason whenever you lie down on the back, it will come and fall and lie on the spine and the pain become worsened is what you need to basically remember. So this is how if you do the CT scan, you can be able to identify an inflamed pancreas. You can also see how much of pancreatic necrosis is there. Is it less than 1/3, more than 2/3, or between 1/3 to 2/3? You can see peripancreatic collections. You can see any pseudopancreatic cyst very close to the stomach. All these things. That's the reason CT abdomen is the investigation of choice. Whenever you are suspecting acute pancreatitis is what you need to remember. So 70-year-old male with hypertension with 4.5 centimeter abdominal aortic aneurysm is undergoing surveillance. Ultrasound imaging has shown it is the modality of the choice to diagnose the abdominal aortic aneurysm. A lot of times abdominal aortic aneurysms are asymptomatic. For some other reason, you will do an ultrasound abdomen and surprisingly you will detect, oh, there is a abdominal aortic aneurysm. So doctor, this is the IVC. This is the celiac artery. This is the splenic artery. This is the hepatic artery. This is the aorta, which is aneurysmal, is what you have to basically remember. So that's the reason ultrasound is very, very useful. A 35-year-old male with history of Crohn's disease present with fever, abdominal pain, and palpable mass. So Crohn's is a risk for developing abdominal abscess, intra-abdominal abscess. So abscess anywhere need to be drained. So you need to drain it and also give antibiotics is what you need to basically remember. A 70-year-old male with a history of the stroke presents with hemiplegia and decorticate posturing. Decorticate posturing. So what does it indicate? It indicates brain injury, and decorticate posturing is because of the injury to corticospinal tract is what you have to understand. So doctor, remember upper midbrain damage whenever it is there. You know, midbrain, pons and medulla. Midbrain is highermost, right? So upper midbrain damage leads to the development of decorticate posturing. Whereas upper pontine hemorrhage, upper pontine damage typically lead to decerebrate posturing. Midbrain decorticate, pons decerebrate. So that is what you have to remember as a benchmark. A 50-year-old with muscle weakness is diagnosed with myasthenia gravis. The disease affects the neuromuscular junction, disrupting the neurotransmission of acetylcholine. So fundamentally, there are voltage gated. If you look at voltage gated calcium channels in the presynaptic membrane, the moment calcium enters, that stimulates the snare vesicles to degranulate and release the acetylcholine. Acetylcholine in turn will go and cause the sodium to move in and initiates the action potential by releasing the calcium across the T tubule, leading to the skeletal muscle contraction. So that is the reason you need to remember this entire chain. Where is myasthenia gravis? Myasthenia gravis is the problem where acetylcholine which is being released is not able to bind with the postsynaptic receptors. And where is Eaton-Lambert syndrome? Eaton-Lambert syndrome is the problem with these voltage-gated channels which are presynaptic. That's the reason if you look at the myasthenia gravis, it does not involve the presynaptic membrane. That's the reason it is not part of lower motor neuron. Only the Eaton-Lambert is a part of lower motor neuron. That's the reason in Eaton-Lambert syndrome there is areflexia, but in myasthenia gravis reflexes are normal because it is not the part, because it is involving the postsynaptic membrane is what you have to basically remember. So now, doctor, a 35-year-old woman presenting with ptosis, with diplopia that worsens with activity, that is decremental conduction, right? She is diagnosed with myasthenia gravis. So which diagnostic test will reveal the presence of underlying pathology? So myasthenia gravis you will identify by doing acetylcholine receptor antibody test is what you need to remember. So this is how the weakness leading to ptosis in case of myasthenia gravis, which is worse by the time it is evening because of the decremental conduction. Now, a 60-year-old male with progressive muscle weakness, you have given edrophonium, which is improving his symptoms. What is the most likely diagnosis? Myasthenia gravis. So what is edrophonium? Edrophonium is an inhibitor of the acetylcholine esterase. Icothiopate, edrophonium, neostigmin, physostigmin. But edrophonium is very short acting. So that's the reason we use it as a diagnostic test. Not anymore, but still for USMLE you should know. So icothiopate, edrophonium, neostigmin, physostigmin, they all will inhibit the acetylcholine esterase and prevents the breakdown of the acetylcholine and increase the acetylcholine level so that even the number of receptors are less, still this increased intracellular response will be there because the increased acetylcholine. That's how edrophonium is used as a test. If there is an improvement in weakness with the edrophonium, that means it is myasthenia gravis is what you need to basically remember. A 40-year-old farmer brought to emergency because of the salivation, lacrimation, muscle twitching after exposure to pesticide. Classical of organophosphor poisoning. So what is organophosphor? It is acetylcholine esterase inhibitor. That means it increases the acetylcholine levels. It is cholinomimetic in nature. Because of that cholinomimetic excess amount of acetylcholine, there are some sympathetic and parasympathetic effects. So if you look at sympathetic, the preganglionic fibers are short, postganglionic fibers are long, right? Parasympathetic, the preganglionic fibers are long, postganglionic fibers are short, right? Now, if you look at sympathetic, there is a nicotinic receptor at the level of the preganglionic and postganglionic level, at the level of the ganglia, where there are nicotinic receptors on which acetylcholine acts. Then the postsynaptic receptors on the sympathetic side produce the norepinephrine, which goes and acts on alpha and beta. So that is the reason whenever acetylcholine is too much, it is causing ganglionic nicotinic receptors of the sympathetic fibers to get increased, and that lead to dumbbells because of the excess adrenergic activity. Diarrhea, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, lethargy, salivation, and seizures. It's called dumbbells. Tell once more, whenever organophosphate poisoning is there, too much of acetylcholine activity will be there because of the too much of adrenaline, that is the noradrenaline levels will typically increase because of the increased nicotinic acetylcholine activity, and that lead to dumbbells. What are dumbbells? D for diarrhea, U for urination, M for meiosis, B for bradycardia. Acetylcholine makes the heart to slow down, and bronchospasm, emesis, lacrimation, lethargy, salivation, and seizures is what you need to remember. Also, there is a sludge. So what is sludge? Sludge is salivation, lacrimation, urination, diarrhea, GI cramps, and emesis in OP poisoning, organophosphor poisoning is what you need to remember. 55-year-old with a history of smoking, alcoholic use presents with progressive dysphagia. Endoscopy shows a mass in the lower esophagus and biopsy confirms adenocarcinoma. So what is your diagnosis, doctor? Alcohol leads to gastroesophageal reflux leading to Barrett's esophagus, which is converting into adenocarcinoma is what you need to remember. So this is the typical histopathology of the adenocarcinoma, where glandular appearance is what you're able to see in adenocarcinoma. And also you can see the presence of the Barrett's esophagus. Barrett's esophagus in the lower esophagus is what you need to remember. So doctor, Shanti, Shanti, Shanti. So with that, we come to the end of today's wonderful beginning of the USMLE Step 1, 10,000 clinical vignettes in 200 hours. Every hour, around 50 to 60 clinical vignettes revision. And to clear your USMLE Step 1, what you all need is this 200 hours with Dr. Murali Bharadwaj and do the revision of 10,000 clinical case vignettes on which all the MCQs in the tomorrow's USMLE Step 1, the 7 sets tennis game, right? So, Rose milenge, Rose padenge, and one day we will see to reach the dreamland of United States. Good night, and we will all see you tomorrow. Thank you.